Good evening. This is Critical Talk on Muslim Network TV. I am your host, Amina LD, and I have with me this evening two wonderful psychiatrists that graciously volunteered to give me some of their time so I can ask my 101 psychiatric questions without having to pay for it. Okay, first we have Layla Park. Dr. Park is in her fourth year of psychiatric residency at the University of Chicago and is currently serving as the chair of the Resident Fellow Committee for the Illinois Psychiatric Society. She did her, she's doing the residency there, and she also attended medical school at Rush and has a number of awards, too many to mention. Dr. Kandai is currently an assistant professor of psychiatry at University of Illinois at Chicago and is working in consultation liaison psychiatry, and I'm going to ask them what in the world that is, and integrated care. He completed his medical school at the University of Pittsburgh, psychiatric residency at Northwestern, a CL fellowship at the University of Washington. Let me welcome both of you.
Hello.
And hey,
Hello. Thank you so
I-
much, Dr. Aldine, for
how
having
can
us.
you all, you're shrinks? How can you be so happy?
You have to be in our line of work.
Never happy. Oh, well, like, there again, because of your line of work, you're happy. Okay. I have some basic and quite fundamental questions because I have found that this is an extraordinary time. You know, living is extraordinary. And all of us, generally speaking, and you can correct me if I'm wrong, have an underlying small, medium, or large mental health problem. And then some of us are off the charts, right? Those of us, and I like to include myself in the first group, who have small problems, usually our coping skills over time have honed themselves to the point of where you don't know I'm crazy, right? But then we get a pandemic and we're asked to shutter in place. And for many of us, does that mean I don't have to go and do anything? It's great for all of about 36 hours. And then all of a sudden, I need everything in the world outside. Just as I get to put all five of my toes out the door, I'm hit with a protest. And it's like, oh my God. Is this the end of the world? What's going on? Then, as I turned around in the middle of the protest, I'm told coronavirus is spiking again. In responses, and the media has not helped me in this. Um, and I thought I knew the difference, but I want to make sure. What's the difference between a psychologist and a psychiatrist? I know if we watch, TV a lot, and I do, one lays you on a couch and the other kind of talks to you from a chair. Beyond that, many in our listening audiences don't know. One is a PhD, the other is an MD. So, whichever one of you wants to tackle that, go right ahead. Let's take Dr. Chanda.
Okay, of course. So we are both similar in that we both deal with issues of mental health. A psychiatrist is a doctor who went to medical school and then after medical school did at least 4 additional years of medical training specifically in psychiatry. So we focus on mental health issues from medical standpoint, whereas psychologists do graduate school in psychology and they focus primarily on it from a therapy and psychological standpoint. There's a lot of overlap between the two, but the big difference is that psychiatrists are medical doctors. So they can also prescribe medication, and they often think about medical conditions that may look like mental health issues. For example, if somebody's thyroid is not acting correctly.
Ah,
It
uh-huh.
could look like depression, but it's not depression. So that person could use therapy, but they could also just use some thyroid medication.
Oh, and
So
Dr. Layla?
Yeah, so Dr. Kandai provided, great explanation. And I also want to stress the fact that we do have a lot of overlap. We often work together, we share our patients, we refer to each other, we train together, we do research together. So I'm at the University of Chicago right now, and my supervisors include both psychiatrists and psychologists very often. And like Dr. Kandai said, we are both part of this mental health care team, along with many other professionals like psychiatric nurses, social workers, and many more.
Well, just to stir the pot a little bit,
Of course.
have you ever run into a case where there's a difference of opinion between the medical? All I see is dollar signs in terms of bills and loans. So, but do you ever run into a clash of opinions? Say, for example, using your example, the person has hyperthyroidism and or hypo, doesn't matter. They're going off the charts one way or the other. And you look and you may or may not see a goiter, for example, but blood work is going to come back and give you some further indication of what's going on there, because I'm going to ask you a question about uh, the DSM a little bit later. But you're going to say, aha, let me see, perhaps, and maybe I'm misreading you. Let me see if I give him some thyroid medication, if I can alter the behavior. Is that what you're saying?
Dr. Kanda, you want to comment on that?
yeah, so what I'll say is that a person will come to a psychiatrist with a concern. I'm feeling sad and I feel tired all the time. Part of our job as psychiatrists from a medical model is to think of what are all the things that could be causing somebody to feel this way. It could be a depression. It could just be they've been having a bad couple of days. It could be a thyroid issue. It could be a low vitamin D issue. There's many things. So based on our talking with the patient, knowing what's her medical history, what else has their family gone through historically, what are the symptoms they're having, we then recommend, like, we should do these further tests to make sure we're not missing anything. And then results come back, we recommend a treatment. In the same way that if you were to go to a general doctor and said, hey, my left knee is hurting, they'll want to ask you some questions to try to figure out all the reasons it could be, and then based on that, do labs and imaging versus just give you something straight away and jump the gun.
Dr. Park, you have anything to add?
So adding on to what Dr. Kandai just said, because we come from different training, educational backgrounds, and also, different personal backgrounds, collaboration is key because of the reason Dr. Kandai mentioned. So, for example, in clinics right now, I frequently collaborate with psychologists who, I send my patients to them for therapy, and I rely on their expertise, and they may rely on my expertise on medication. And in the emergency room, I frequently work with social workers. We share information, we talk it out, we talk about the patient and try to approach the patient as a whole person. So collaboration really is the key.
Okay, let me just, for my own personal knowledge and for our listeners, what are some of the major categories of psychiatric illness? We know that everything that might look bad is not necessarily bad, but what are some of these major categories?
So some of the broad diagnosis categories that are in the DSM-5 include things like...
What is a DSM-5? Don't you all whip me to death with acronyms.
Oh, perfect. I have it right here. Diagnostic and Statistical Manual. Oh, yeah. So this is a manual that we use to diagnose different types of mental illnesses, right? So in it, some of the broad categories include things like depression, bipolar illness, schizophrenia, anxiety, trauma-related disorders and substance-related disorders. Those are some big, broad categories. Now, unlike diabetes, asthma, COPD, or like hypertension, a lot of these diagnoses rely on symptoms that patients tell us, right? So that means we sometimes have to make subjective judgments about, like what is normal and what is not, like what is a symptom of an illness and what is a symptom of the opposite of illness.
And to add on to what Dr. Park was saying, a big thing in psychiatry is because we don't have a blood test that tells people if they're anxious or not, right? And because everybody gets sad or anxious or stressed at times, we can't just call everything an illness, right? Because if everything's an illness, nothing's an illness. So what we do in psychiatry is we talk with the patient, we try to figure out, is this what a person would normally be experiencing in this situation, like within the normal range of emotion, or is this more than is healthy? And more importantly, is it impairing the person? Is it getting in the way of them being able to live their life? So for example, if somebody can have a bad day and be anxious, if anxiety goes on for months and months and months, and the anxiety is so bad they can't even live their life or do the things they need to do, that's concerning. But our goal is never to tell people that just because you're anxious, like you have a disease. Like I'm a little anxious right now, like talking with you, being like, I hope I like look good and I tell everybody like what they need to do here and I help people. But overall, I think I'm doing okay, like living my everyday life. But like a patient I just saw today, like she's in the hospital and she's anxious, but she can still like work with the doctors, get the treatment she needs. That's just, I'm anxious because I'm in the hospital. Like that's okay.
Okay. Now I think that is clarifying from both of you because I know most people have never seen that book, which I'm sure after COVID and protests and COVID again is going to expand exponentially to include all these other things that have been brought to the surface. But in that, I had a list of stuff. I know for a fact, purely because I'm old enough, that back when I was 2, Ronald Reagan closed mental health care facilities, like a sweeping, and by, at 2, you don't know, really what that means. As I got older, however, it meant that patients with serious mental illnesses really didn't have a place to go. And then on the other hand, hospitals shrunk the places, the number of beds, I found out even later, where patients could get in. I want you to talk about that. And then I want you to talk about the effects of COVID-19 on your being able to distinguish between the homeless who are going to use the emergency room and the psych ward to get a place to rest, many of whom also have psychiatric illnesses and no insurance, because we can't talk about hospitals and you guys without talking about insurance. And then the person who actually has insurance or cash money and feels themselves going off the deep end. So you can start back, if you would, try to give us your thoughts on what has happened to the history of psychiatry. And say, I don't want to put you back with Reagan, but 2 days after Reagan.
Dr. Park, if I could start off with more of a historical context, because that's actually just explaining this to some medical students today. So even going before Reagan to the era of like Jimmy Carter and Nixon and Kennedy,
I wasn't born yet.
For a long time, we didn't have any real treatment for people with schizophrenia, bipolar disorder, depression.
Can you slow down?
Of course.
I hate to do that to you. Explain schizophrenia.
Yes.
Schizophrenia with paranoia. Paranoia perhaps without schizophrenia. And please, please, please explain bipolar disorder.
Okay, so schizophrenia is a psychiatric condition where people have a break from reality. So they start hearing voices or seeing things that other people can't and don't make sense and are often frightening. They can get very paranoid, thinking like people are not just following them, but out to get them. They have problems organizing their thoughts and they often don't make sense. And also comes with changes in their brain that make it harder for them to process, focus, pay attention, read emotions in other people.
God, I got all of those. Okay.
And what happens is it usually develops like in the late teens, like 20s, 30s in some people.
Why?
What we don't know fully what's happening in the brain, but at this time, what is thought that the brain, how it's normally supposed to be developing, it just starts going a little sideways, not developing as it should. So people who are otherwise, for lack of a better word, normal or not ill in their childhood and teens, what happens is they start getting a little bit more scared. They start shutting off from around the world. They may start using drugs like marijuana or alcohol more. Their grades or their jobs start slipping. And then soon, basically, their brain disintegrates and they just aren't themselves or the person they were anymore. And they start hearing voices and seeing things all the time. They get really paranoid. They don't make any sense. And so they get really sick and they need help. So for a long time, like 1800s, 1900s, we didn't have any treatment for this. So these people were in what we would call the old state hospitals, where they would stay for like months or years at a time. But in the 50s and 60s, we finally developed medications that could start helping people with these conditions. And what we thought at the time was this will cure people. They never have to be in a hospital again. And so people, progressives and liberals, they're like, we don't want people stuck in the hospital forever. Like one of shut all the hospitals down and get people out in the community and have people with these treatments, but give them social workers and the community support they need. But the conservatives, the Republicans, were like, let's shut all these hospitals down and save some money. And so what happened was both sides thought this was a great idea. So they shut down all the state hospitals, and that's kept going up until this day. But unfortunately, the funding for community health centers and getting people the help they need in the community never happened. So all of these people who were at least safe in a state hospital before, they are now all homeless, roaming the street. A lot of them are Black and brown and getting caught up by the police, and they end up in this revolving cycle of being homeless, being in jail, being homeless, being in jail, which is why the single largest provider of mental health services in the country is actually the Cook County Jail and prison system.
Yeah. So I want to point out, thank you, Dr. Kandai, for the historical context. And I want to point out that the two things that you just mentioned about closing of inpatient psychiatric hospitals, as well as closing of the public mental health clinics that that was run by the city of Chicago. This was about like 10 years ago. The two things happened kind of simultaneously. I want to point out that we were going through a recession at that time, right? 2008. And we need to pay attention to this because we are about to go through another recession. Right? And history often repeats itself. And we know based on history that, during recessions, we see budget cuts and often things that negatively affect the Black communities and minority communities, immigrant communities the most, such as mental health care, right? And so that's what happened about a decade ago. And what did happen during that period of time is there was a surge of people presenting to emergency room, a surge of people relying on emergency room for their mental health care because there's no clinics for them to go to. Well, not no, but there were fewer numbers, right? And I want to talk about that for a second. So what does that mean? What that means is that when patients come to the emergency room, they may be psychiatrically ill, but it puts us psychiatrists in the position of sort of a guard or gatekeeper to the resources because resources are limited. The psych beds there's not enough for everybody. And so we play this strange role trying to allocate resources, trying to decide who, quote unquote, like deserves the care or treatment, right? So one of the studies actually I have done at University of Chicago Emergency Room is studying which patient, who are the people who gets the diagnosis of what we call malingering. And I'll explain that a little bit. It's basically calling the patient that they're lying. I know it sounds really bad, but that's like the simplest way to put it, saying that they're exaggerating their mental health symptoms in order to gain something else. Okay, that's kind of the definition of it, calling them kind of a liar, for the lack of better words. So, you know, when I study the data of people who gets labeled malingering, this diagnosis more often, they're often Black people, they're often unhoused homeless people, they're often people who don't have access to substance use disorders and mental health illnesses, which is, this is a public health crisis, right? This is a health inequity issue. And like Dr. Kande mentioned, a lot of these people, they go through this like cycle of coming to the ER. And then what happens is, you know, Southside Chicago, we are in this mental health desert, right? And so sometimes they get, well, often they get arrested and sent to jail and prison. And I think the rate is about like 30% of the Cook County jail inmates right now have that mental health diagnosis. But it's really shocking that that's where
exactly, like how is jail going to help your mental health? Exactly. I want to go back to Dr. Chandan providing us with some definitions. What is bipolar?
So bipolar disorder is a disease where you have two states. One is you can be in a depression, so you're having low mood, low energy, feelings of guilt, worthlessness, having thoughts times that you want to be dead or even take your own life. But on the other hand, you could have times where for days at a time, you don't need as much sleep. You feel like you have a lot of energy. Your thoughts are going really fast. You have strange ideas like you have powers, that you are God, you are Jesus Christ, you are the president, you have superpowers. You can get irritable really easily, and you start doing dangerous things that you normally wouldn't do.
Like to yourself or to others?
To yourself and to others. So for example, somebody who's in what we call a manic episode, they can do things like go roaming the streets, naked, thinking that they're going to save everybody with their powers, or they could go spend their entire paycheck buying 5 or 6 cars, thinking that they're going to give them as gifts to friends. Like people can burn through their life savings, like while in a manic episode.
Wow. Yeah. Now the other one, I'm just in my definitional phase. It's not in the DSM, guys. Now, one of the trends beside bipolar stuff, and I'm really curious, and I want both of you to think about the age range at which it's happening, and the developmental phase or the extra pressures from learning a skill or going to college, what potential role that might have. But this is this alphabet soup of stuff that's being put on kids. All of us know that most, if not all, well, with the exception of things like what is it, Ativan and Valium and some others, most of the other hard, I'm just calling them that for lack of a better term, hard psychiatric drugs are processed in the liver. And they're what I'm a pharmacist, what we call fatty tissue drugs, right? It's going to take them a while to have any effect at all because they're building up stuff in the bloodstream. If I put a patient, that's a bad choice. If you put a patient on Haldol or one of the other wonderful drugs, and you keep them on it for a considerable amount of time, the chances of them ever coming off of it are zero. What about, I've had students on, what is that, Atarax? Is it Atarax? No. Is it Atarax for the jitteriness and stuff that I don't know who's prescribing it, their family physician, something.
Adderall.
Adderall.
Treatment
That's
for
the one.
ADHD.
I mean, they even share them in the university, you know. And I wonder about family physicians prescribing them because mom or the kid, because they heard from somebody else, this is what you need to taking it. But I also wonder about that short but powerful list of drugs now being given to children with well, they're too busy, they won't stay still. They're all over the place. It's not that they're having strange utterances, which is a different category of stuff, but they're just talking all the time. They can't focus on anything. What do you think about this trend? Dr. Kandai. I
Okay.
know. I know.
So I think what you're referring to is attention deficit
Syndrome.
hyperactivity
Yeah.
disorder, ADHD.
Yeah.
And there's a lot of controversy around the diagnosis. A lot of people say that it's being overdiagnosed. That would take what's normal childhood, like jitteriness, inattention, like tantrums, and calling it a disease and putting kids on treatment unnecessarily. But there's also points to be made that ADHD, like the true clinical condition, is being underdiagnosed in Black and brown children, and they're just being labeled as troublemakers. So if it is a white kid in the suburbs with these same symptoms, they would be given ADHD and put on treatment. If it's a Black kid, they're just being a problem child. They need to be taken out of
And
the
put on a
class, or they need
special
to be put in
program.
timeout. What's really important is if your family is having a child who you think may have something going on, where they have difficulty paying attention or staying still or not being able to focus on schoolwork, that you talk to a general or family doctor and be like, I'm concerned for this. But then also, if necessary, get special testing or provide school records so we can see, like, is this actually a disease, or is this just acting out because they're being bullied at school, or they're having a hard time adjusting, and so on and so forth.
So but these parents are living in health deserts, literally. Where are they going? I mean, a lot of parents get their health care from a free community clinic, or if one of the hospitals happens to have a free clinic. Very few of them have a private doctor. I mean, it gets really weird. So I guess until you guys write a paper or come up with something, it's going to remain that way. I don't know. I'm looking, there was a time when parents said, you better sit still. So people who had ADHD, whatever, sat down. Now, any movement, you might get diagnosed with something, whether you're the white kid in the suburb or the Black kid who's going to wind up in an alternative school in the city. I'm just wondering about, if do the two of you think the diagnosis is accurate?
Okay, so I have two thoughts on what you just said, Dr. Aldine. So one is, as we discussed earlier, the diagnostic criteria, there's a subjective component to it, right? And in the psychiatric community right now, my understanding is that we talk a lot about how some of these criterias, they need a little bit more of cultural aspect, should be ingrained into it. Like I wonder, a lot of these diagnoses, they may be masking something like trauma, right? Like adverse effects that some of these kids are experiencing. So that's one thing. And I just want to say, good news is that there's a DSM-5 committee, right? So they're working on the revised edition, is my understanding. One of them is working on that.
They're gonna have fun.
And he assured me that they're gonna make sure that every single diagnosis is going to be examined, through the lens of, is this culturally, are we being culturally competent here? So that is some progress there. And another thing I wanted to mention, because you bring up kids in school not sitting still, and Dr. Kanda, you also mentioned that, you know, Black and brown kids are less likely to be diagnosed, given the diagnosis of ADHD, and be labeled as problem kids, right? So kind of going off of that tangent, I also want to mention that, you know, a lot of schools, they rely on police force for disciplining these kids, right? Rather than relying on social workers, psychiatrists, psychologists at school. And so, you know,
There are none in the schools.
there's
That's the
a
problem, right?
severe shortage. And when you combine the two, what happens is you see more Black and minority kids who end up in not mental health treatment, but rather ending up in, you know, arrests, like handcuffs and things like that, which is very
Well, you
problematic.
know, when we get to the conversation about cultures, and fortunately or unfortunately, we're a multicultural society, and cultural constraints, what families can talk about or can't talk about until it reaches a crisis point, has got to be a sticker for you guys. I mean, even what I can say, let me take for example Japanese society, where the patient, older person, is very, very ill. The kid, maybe in his 40s, comes along and tells the doctor, well, you can't tell him how ill he is. You know, you got to hide it. I mean, cultures have all their quirks. How are you beginning to handle culture and all of its quirks?
How are we beginning to handle these
Yeah,
quirks?
it's lots of it. I mean, it's Black and brown kids, it's Muslim kids, Hindu kids, kids from small Christian evangelical sects. It's Jewish kids. It's, let me think of somebody else, Sikh kids. It's, I'm running out of people, not because I don't know, but do you understand what I'm saying? Everybody comes, and especially with regard to mental health, there
Mhm.
is no culture that appreciates mental health. We want you to be healthy, whether you're healthy or not. What do you do? Today, docs, do not go to sleep on me. I know you're
So
tired.
I will say that it's not just a job of psychiatrists. Like every doctor
Yeah,
needs and should get training in how to work with people across different cultures and backgrounds, because
yeah,
that's our job, right? Because
yeah,
everybody has a body, everybody has a brain and a mind,
yeah.
and everybody suffers and gets ill and needs help. So one of the benefits of a multicultural society is that you can also learn from
Mm-hmm.
other cultures too, and see how other people handle things and play to their strengths as well. So a good doctor, and not just psychiatrist, a good doctor will be able to appreciate that and do something that meets the person where they are. So we talk about this concept of patient-centered care in medicine.
Yeah.
And what that is not just you coming from up on high being like you will do this because I am the doctor and I tell you to do so. You say,
Mhm.
hey, this is what I think is going on with you. I'm really concerned. I want to recommend this. What do you want? What do you think will be helpful for you? And then meet them halfway.
Okay. How are you going to translate that to families? Because families, when there's one available, are critical in healthcare. How are you going to translate it? Because mental health, irrespective of what year it is, has a stigma.
Mm-hmm. So I think part of that work involves two-way communication, right? Like Dr.
Mm-hmm.
Kandai mentioned, we want to ask the patient what their experience is like, and we want to ask the families, hey, what is your experience in handling things like this? Have you had
Mm-hmm.
to handle things like this before? And what is your experience like? And another part of that is, you know, we just mentioned it's a multicultural society. Back in the day, I believe the training used to be like, oh, learning what, for example, like what an Asian patient must think or see things like mental illness, right? Or what a like Latinx person.
Any old Asian? I mean, were they all lumped in one bucket? One
Well,
any old Asian?
that's a whole
Didn't
other
matter.
problem. It's a whole other
Oh
problem,
my
Dr. Aldine.
goodness.
But you know what I mean? Like back in the days, like we would, that was like a cultural psychiatry curriculum. But nowadays we have shifted towards more like, instead of trying to learn and memorize like what each culture, people of each culture will think and do, we are now more focused on, ask more questions and try to learn more about the individuals and ask them about like, having the experience that you had, what is your understanding of X, Y, and Z? How do you normally go about solving problems and things like that? So it's been a progress there.
Since we're in I think at one end or the other of a pandemic. I'm not sure where we are. Depends on whether you listen to CNN or MSNBC. And we also know that there are protests in the street. People their anxiety level was already through the roof. Those who had undiagnosed situations, those that had diagnosed situations. How do we manage this for our own mental health? And I kind of come back to Dr. Kenda. I mentioned D3. Someone called me and asked me if they could take, what was it, 50,000 units of vitamin D. And I said, whoa, well, you won't code, you won't have nothing. It's just interesting the kinds of misinformation that is out there, because while the CDC has put out a list of things that we can do, for businesses, workers and clients, the mental health professionals have been kind of clandestine. What can we do?
So can I go first? So two things I noticed about, the pandemic and the protest, right? Everything that we're living through right now. So one is we know in our line of work, we know that experiencing and seeing health inequities happen in front of us, and exposure to violence, right? Exposure to trauma, things like this. All this will result in increase in rates of things like, depression, anxiety, and PTSD, things like that. So that's one. But I kind of want to present the other side of this as well, of the struggle that we're going through right now, is that, when you go out there and in the protest, or you're watching the protest, right? And you realize that this is an issue. Everybody in the protest, they care about this issue. We have come together as a community to validate what Black people have been going through. You know what I mean? There's that validation, there's that solidarity. And in a way, I wonder if that's kind of like a mass
cathartic.
Yeah, exactly. Like a mass therapy for right? Yeah. So it kind of gives hope. So that's kind of the two sides of the protest.
Dr. Chandan.
So I'll say in this similar way that we know that like exercise is generally good for you, right? But should everybody go and run a marathon? No. You should talk to your doctor and take your own situation to account to be like, am I ready to run a marathon, or could it do more harm than good? So in the same way as Dr. Park is mentioning, like there's a lot of emotional well-being and support that people can get from taking part in protests, feeling like they're part of something that speaks to their core values. But it's always good to just, especially if you have an underlying psychiatric condition, talk with your psychiatrists and healthcare professionals, things I should do to keep myself safe, things I should be aware of. So say, for example, you're a strong proponent of Black Lives Matter, but you also get really bad social anxiety being around large groups. So keep that in mind if you're going to go to a large protest. Maybe make a plan for yourself. Hey, I'll only be here a few minutes, or maybe I'll be more around on the outside. And if I start suddenly feeling panic, like I'm trapped, I have a way to quickly get out of that situation. So I don't get triggered too much.
Very important. And I think some folks, nobody told them that you need to have an exit strategy. They just went, I want to do this. And then when they saw 9,099 people behind them, freaked out.
Mhm.
Now, let's take it to the other side of that, talking about protests. The police have got to be feeling, in addition to anger, for many of them, being told that they do something that probably never occurred to many of them. And oh my goodness, what do you know? Some of them are young enough to have never lived through a riot. Who's providing their mental health care?
So I can speak to that. So I actually am now working with Chicago Police Department on their mental health training. It's called Crisis
Yay!
Intervention
I
Training.
know somebody that's doing it.
But one of the things that is discussed during the training, which I've sat in on, is mental health resources for police.
Okay.
So police, like many organizations, have like an employee assistance program. And police, like doctors, like firefighters, like other public servants, are really bad at taking care of their own mental health
Yeah.
because their whole job when a crisis is happening is to run towards the crisis and not
Right.
away.
Yeah.
So in a lot of our fields, like police, medicine, nursing, firefighting, when you're a public servant, you don't get to go home and stop being you. It's a calling. It's who you are all the time. And when you spend your whole life thinking about how to serve and help other people, you get really bad at remembering to take care of yourself. So one thing that Chicago Police Department is working on internally is making sure that police officers know that, hey, when I'm having a lot of stress, when I'm having a lot of anxiety, a lot of depression, when I'm not feeling my best mentally, much like in the military, that's not
Anybody
a
else?
sign of
Yeah.
weakness.
Yeah.
I should get help so then I can continue being the best police officer I can be.
Well, the one of the other things, and I think Dr. Layla mentioned it earlier, and you mentioned it way back when, is the police are saddled with doing your job, the counselor's job, the sometimes the EMT's job, sometimes the arbitrator's job. I mean, they
Mhm.
have so many hats that they're not qualified to wear. They're called for everything. My cat is up the tree. My kid has a butcher knife at my throat. I mean,
Mhm.
any and everything becomes a 911 call. Some things, of course, need to be a 911 call, but I'm just saying that must increase their feelings of unpreparedness in
Mhm.
many instances, which is going to create an anxiety and perhaps even a depression. And since you're doing it, are are you focusing on some of those? I heard today that some police departments are looking at compartmentalizing what police are there for. It's one thing to say you're there to protect and serve, but I'm not, you're every man.
Mhm. Yeah, I think that's part of the issue here that police cannot and should not be doing everything. And part of the thing that they're doing is that they're kind of like street psychiatrists, right? They are often the first responders to mental health
Mhm.
crisis. And like what Dr. Kande is doing, there's this initiative.
Awesome.
Yeah, so Chicago has been training their police officers on, is it CTI, I think, right, Dr. Kande?
CIT.
CIT training. I think, how many people are trained now? I think about like 15, 20%. But anyway, so that training is going, but the question is, there's a lot of discussions around that too, right? Like, should this be like mandatory for every single police officer? Should it remain voluntary? Is
I
that
think
training
so.
enough?
Not that I'm a police officer,
I
and I
think so
want
too,
to
yeah.
keep him employed in case I need for him to come back on the show again. But I want to think about another aspect of mental health care.
Okay.
Back in 1987, I think, during our Iran hostage crisis, You all are too young to really, really remember it. But it was the first time we as a nation had 24-hour news cycles. It was new. And Ted Koppel was there. And oh my God, people were becoming sleep deprived. You know, they had never seen the possibility of 24-hour news. Then, and even then, it was singularly focused, right? Now we just came through one, let me see, March, April, May, still a little bit today, but 3 solid months of corona, corona, corona. Lots of misinformation. People did not actually know what to do. They were drinking bleach and other kinds of disinfectants. They were, I mean, I watched in amazement, but they actually, their mental health broke down to the point of they could not distinguish, as you, Dr. Chanda, were describing previously, they could not tell reality from non-reality. I mean, why would you drink some bleach? But nevertheless, now then we had 2 weeks of protests. It's one thing to see people in a peaceful march. It's another thing to see police and others in your face with great big old guns, as if we're at war. And how does one process that? And what are you guys going to do? Because next week you're going to have it showing up everywhere.
I don't have a good answer for that. It's a very complex question, but I do want to say we as psychiatrists, I mean, as physicians, as healthcare professionals, I mean, as human beings, I think we all have a role to play in this, right? So one thing I can think of top of my head right now is to take a more active role, like, have our voice heard about the concerns that we have, that this is witnessing this amount of violence. It's going to negatively affect everybody in this country. Everyone is going to be traumatized.
And they're running out of psychiatric drugs. So much is being prescribed to dampen people's anxiety. Some of them who have mild cases of COVID or even moderate cases, that where you want the patient to stay at home and not necessarily be, hospitalized because they don't need a respirator, ventilator, or any of those things. Plus, now you got all of our anxiety and we need rest. Scared to death we're going to miss something on Rachel Maddow's show, or something. So we're getting 2-3 hours of sleep a night. Any suggestions? I know these are weird questions or questions that need a lot more reflection we can have now, but the top of your head, trust me, is better than CNN.
I think COVID-19 has created unique challenges for psychiatry and mental health, because when people get really anxious and depressed, part of what we recommend from a non-medicine perspective is doing things like going outside, engaging in exercise, socializing with others, like doing hobbies, and COVID-19 has placed some constraints on that, but doesn't mean that life has to shut down. Like maybe now instead of meeting with your friends somewhere, you do a Zoom talk or a conference call with them and just check in with each other and see how you're doing. Maybe instead of just watching the news all the time, watch something that's not the news, or even better, like read a book. For the youngsters listening, that's something that's on paper.
Thank you for that.
Don't need
Thank
to
you.
plug in. You can just read it. We found that people who watch a lot of TV right before bed, they have trouble sleeping because the brain's visual centers are being stimulated too much by the TV or the smartphone, and then it's hard to turn off and go to sleep. But if you read like a physical book or a Kindle without backlighting before you go to bed, it can actually help you sleep better. So we have to change the ways that we help people from a mental health perspective, but they don't have to go away. And I
Do you think that social media is playing a role in this too? Because I know my granddaughter, for example, has Snapchat, TikTok, Instagram, Facebook, and I'm missing one.
that's a bit much. That's just, I don't know how to keep track of all that.
I don't either, you know. And I'm saying, what are you doing? Are you reading all of this? And I know it's become a fashion accessory more so than anything else to say I got all these things because nobody can read that much. But they're trying to see what their friends are saying about stuff instead of listening to the professionals. And that seems to be a trend of this 20-something-year-old group. You know, my friend will tell me what to do. I mean, there is even an app for meeting or getting a date online.
There's many apps for that.
I know. Across cultures.
Yeah.
It's crazy. But let me, before I let you go, how is your mental health? And my office hours are 9 to 10 at night on Sunday.
I know I've been getting some bills.
How is your mental health?
I will say, actually, this is kind of connected to what you just said about, media and social media and all that. I've been learning that it's very important to be kind to myself. I often struggle with this, but being able to recognize that I'm important. I need to pay attention. I need to take care of my mental health so that I can take care of other people, so that we can do our job as a psychiatrist, right, Dr. Kande? So taking some time, even for a few minutes out of my day, and
because we don't think you all are human. We think you're supposed to function 24/7.
Exactly.
And we want to be able to call you 24/7.
So I'll say that personally, I actually see a therapist. I've been seeing one since I was in residency. And I think it's very helpful, both for me personally, but also just to learn how to be a better psychiatrist. Like there'll be times when I was doing therapy as a doctor and my patient will forget to say something until the very end of the session of therapy. And I'm like, who is that person? Why did you wait till the last minute? What type of game is he trying to pull? And then I caught myself doing it the other day, and I realized people just forget to talk about things. It's not like some ulterior motive. So it's helping me learn how to be a better therapist by doing my own therapy. And I think by letting you and your viewers know that even as a psychiatrist, like I get benefit from therapy, hopefully it'll make other people feel more comfortable doing this thing, which for a long time was thought to be just for rich white people lying on couches with paying cash out of pocket. Like it doesn't have to be that, right?
Yeah,
therapy is for everyone.
Absolutely, Dr. Kande, and I second that. I am also a patient as well. I can be a patient and a physician, right? Patient and a healer.
I don't think that me and my view, I mean, I kind of know, but I know that many people don't know that you, or even think that you have to take care of your own mental health. The only thing you need to do is serve me. So it's important that they know that you are cognizant of that, taking care of it. Last point, and I know you all are so sick of this. Questions. Anything we didn't cover that you think is very, very important? Look, I am in heaven. I got 2 shrinks on the line. I have never had 2. Questions? Things you want to remind our listeners of? No?
So I'll say that I think even if you don't at this moment want to see a psychiatrist or go into therapy or even talk to your doctor, like talk to somebody if you're not feeling yourself right. Like just because COVID-19 has put like social distancing on us doesn't mean we have to be like socially isolated. Human beings were made to be social creatures. And I think knowing that it's okay to not be okay all the time. Part of my job is
Thank
I
you.
help
Yeah.
take care of the mental health of like doctors and nurses at UIC hospital.
Mhm.
And one of the things I keep reminding them is you don't have to be okay 100% of the time. Like you are doing a very important job. So even if you need 5 minutes just to like catch some feelings for a while,
Uh-huh.
take those 5 minutes and then get back to what you're doing. And I think as a whole, as you mentioned, Dr. Aldine, if we can just have more grace and have forgiveness for ourselves,
Mhm.
then that'll help us get through this.
I got
stressful time.
a question on the chat that talked about sleep hygiene. What do I wash my sleep? What is sleep hygiene?
So sleep hygiene is a set of behaviors that we can all practice. Non-pharmacological approach, meaning not like medication, but behaviors that we can kind of change and do
Ooh,
to improve our.
our.
Be very
Okay.
still.
Yes.
Yeah. So some of those things include things like avoid watching TV and looking at your phone, like limiting screen time so many, like an hour, 30 minutes before you go to bed because of the blue light,
Mhm.
right?
Mhm.
Things like limiting your caffeine intake after a certain hour of the day, and some people have like a routine that they perform to
So
kind of
that's sleep hygiene.
Yeah.
You can Google it, sleep
Ah.
hygiene, and there's a bunch of things you can do before you go to taking a medication to go to sleep. That's something we discuss with all of our patients who come to us
So
with insomnia.
don't OD on NyQuil every night.
No. No, like for example, like again, as an adult, I take like sleep for granted. I love sleep. Like I can't wait till I go to sleep. But when I was in Seattle
Oh
like
my
last year,
God.
I was with like I had some nephews who were like 4 years old, 10 years old, and that's when I
Uh-huh.
remembered that kids are really bad going to sleep. Like they will not, and I'm like, "Are you not tired, child? Like I can't wait to go to bed." And that's when I remembered that sleep is a learned behavior. You have to learn how to sleep. It's a skill.
Yeah.
So even in our
Mhm.
adulthood, we can train our bodies to sleep better. So doing things like before you go to bed, you have a routine. Like I'm going to change my clothes and my pajamas. I'm going to brush my teeth. I'm going to put in my routine. I'm going to read before bed. The brain then learns that, okay, these are the behaviors to start winding down your brain. So kind of like
Mhm.
shutting down your computer the right way versus just closing the laptop. That way your brain gets into a sleep mode and it can sleep better.
Mm.
So in the same way that I
So
don't just have a pill to help people lose weight, it's a whole bunch of behaviors to help people lose weight and be healthy. Healthy sleeping is a set of behaviors that anybody can do.
okay. Yes, ma'am.
There's one more thing I want to say to the viewers. There's a lot going on right now. Struggles, right? And it's okay to feel however you feel. Like Dr. Kandai said, it's actually very human to feel however you're feeling right now. That's what I wanted to remind everybody.
Well,
That's
I
a human
think people
thing.
wanted to know that, and I think that if we watch television, sleep is has been commercialized by this, by that, by the other, to the point of you don't know really what to buy, and then it becomes you stand the chance of becoming addicted to some medicine. Uh, the fact that CNN and MSNBC are so repetitive, if you miss it, you're going to catch it the next morning anyway. So I think that that helps some, don't help me, but thank you for that. Dr. Park and Dr. Kandai, am I pronouncing?
That is correct. Yes, thank you.
Yeah. Yes. I can't tell you how much I appreciate you being with me on Critical Talk. You've given us so much information. I want to intrude into your well-being again at a future date.
We can go
And
for a couple more
if
hours.
Oh, stop. If you run across something that we haven't covered, send me a note and I will make sure we do. Thank you very much. And to both of you, good night.